Hello and welcome to this video series on occlusion. In previous video, we discussed about function versus dysfunction in relation to TMD. In this video, we will discuss about how to do examination in relation to TMD. So when you are doing examination to assess patients with TMD, you need to start by asking questions. Questions such as, does your jaw get stuck or lock? Does it feel stiff in the morning? How does the pain work when you feel? Does it hurt when you chew, when you yawn? Is there any other areas of your jaw in pain? Making a very good, thorough questionnaire helps. You need to give that questionnaire beforehand to patient, so that reduces your clinical time, but also patient can fill out in their own time without having to worry about the time. The other thing you need to take is pain history. Pain history is very, very important when it comes to temporomandibular joint disorders. So you need to ask questions such as location of the pain, when did it start, the onset of the pain, characteristic of the pains, sharp, shooting, what makes it worse or what makes it better? Is there any history related to pain, or is there any other pain associated with the same pain? Has the patient gone to other consultants? Because if patient's been to 10 different specialists, you need to make sure that you understand your limitations unless you are specializing in temporomandibular joint disorders. I tend to personally refer those patients because I'm a restorative dentist and I don't treat extreme temporomandibular joint disorder patients. And that's where you need to understand your limitations. You need to ask patient about if they have had any psychological assessment done. Now this is very sore subject, so you need to make sure that you put this across to patient in a very mild form. And usually this is done by a specialist. And these type of patients usually doesn't come across our practice. However, if they do, you need to be able to assess them and make an appropriate referral if you cannot treat them. The other thing you need to understand when you're assessing pain is referred pain. Referred pain can be from anywhere from the body, so you need to understand the concept of the source of the pain and the site of the pain. Source of the pain is actually where the pain is originating from, whereas the site of the pain is where the pain's gone. So you could have a source of the pain which is a trapezius muscle, but the site of the pain could be TMJ or near the TMJ muscle area. So you need to be able to differentiate that whether this is the site or the source. Many times it could be the same. Site and the source is the same area. However, sometimes it could be different, and that's why we call it referred pain. So how do you know whether this pain is a referred pain? What you can do is try and relive the pain. So which means try and elicit the pain by pressing the area or doing something which makes the pain worse. Now, if you pressing the area at the site and the source is a different area, patient will not feel pain. However, if you press on the area where the source is, the area of the site will get painful as well. Similarly, if you are giving, let's say, injection to the site to numb the area to see whether that's the area where it's painful, pain may not go if the source of the pain is different. However, if you are giving local anesthetic blocking at the source of the pain, the site of the pain also will go. So you need to be able to understand and appreciate the referred pain, which we are very well trained when it comes to teeth, but it's a similar concept apply with the muscles as well. So when it comes to doing examination, apart from just taking history, you need to do thorough muscle examination, which we demonstrated in clinical examination video. You need to assess the TMJ examination for any joint sounds or pain. You need to do thorough dental examination to assess any fracture, wear, or any mobility of the teeth, any pulpitis, any hypersensitivity of the teeth. This kind of thorough examination is very, very important to assess patients' teeth. Once you've done that, you need to go one step forward if you haven't made diagnosis by taking radiographs. Radiographs are not as much helpful as clinical examination and history taking. However, they can help in some cases, such as you can take periapical of the mobility of the teeth, and you can see this J-shaped lesion where you can see it could be from trauma, from occlusion. You can see, you can take panoramic X-ray to see the overall picture, but you can see a lot of superimpositions. You can order CBCT scan. However, the radiation is quite high and it's a static movement, so you cannot see a dynamic movement of the jaw to assess the capsule or the disc. The MRI is a good way to assess temporomandibular joints. However, they are expensive, and because of that, most of the time not used in general dental practice and only used in hospital settings. So when it comes to doing TMD, there are two main types of disorders. You have an intracapsular disorder, which is within the temporomandibular joint, and you have extracapsular disorder, which is really related to muscle. So that's why it's called muscle disorder. So when patient comes in pain, many times these both can be intermingled. So you can have intracapsular and muscle disorder together, primary intracapsular, secondary muscle, or primary muscle, secondary intracapsular. So you need to be able to differentiate where the pain is coming from. And there are some factors you can assess and check in order to differentiate, make a differential diagnosis. These factors are history, mandibular restriction, mandibular interference, acute malocclusion, loading of the joint, functional manipulation, and diagnostic anesthetic blockade. So let's go through them one by one. So if you're taking history, the patients with intracapsular disorder may present with you a recent history of trauma, and acute pain starts straight from the trauma and persists or gets worse over the time. Whereas the muscle pain could go high and low. It could get severe to mild without any initiating event, and it is closely related to the stress or emotional stress of the patient. So it fluctuates, whereas the intracapsular pain, if it's related to trauma, then patient gets trauma and it gets worse and worse and worse, and there is a definite start point when it comes to intracapsular joint pain. Mandibular restriction. When you're assessing mandibular restriction or mouth opening, you need to understand the concept of soft end feel and hard end feel. What does that mean is that when you ask patient to open their mouth and you diagnose that the patient has a limited mouth opening, if you put two fingers between their teeth and try and pull the jaw apart a little bit, if you manage to move the jaw a little bit and you feel it's a little bit softish, or it gives a little bit, that calls soft end feel. However, if you try and move the jaw apart and it's just rock solid, then it's called hard end feel, which means you cannot move the jaw at all. And when it's important to assess this when it comes to doing differential diagnosis, because intracapsular disorder jaw has around 25 to 30 millimeter mouth opening, which is limited, and it's usually a rotational movement. When it comes to doing slide movement or translation, the jaw doesn't go forward because the capsule's in a way, or the disc is in a way. The jaw would feel hard and feel. The contralateral eccentric movement is limited. However, same side movement is normal. and this is what you will see. However, with the muscles, it can occur anywhere during the opening movements. The pain can occur anywhere. It could occur, the mouth opening can be restricted 15 millimeter. So usually the good way to indicate is if patient can only open up to 15 millimeter, most likely it's a muscle pain. Okay, because usually with a capsule, with a disc, an intracapsular joint disorder, patient usually can have a fully rotational movement, but not translation. Whereas the muscle pain could be anywhere. However, when you try and open it a bit wide, patient can open wider a tiny bit, and that's why it's called softer end feel. Because mainly the elevator muscles are affected, the eccentric movements are usually normal. So the third factor is mandibular interferences. So what you will see is when patient have intracapsular disorder, the mandible will often deflect to the side of the involved joint during the protrusion. So it will deflect on the side. Let's say if the right hand side is painful, mandible will go on the right hand side when you protrude, and there is a restricted movement of the contralateral side. However, if you're trying to go on the same side, it will be a normal movement. In a masticator, when the muscles are affected, there is no real deflection during the protrusive movement, and there is no restriction in lateral movement. It's just painful. Acute malocclusion closely related to the event. So if it's intracapsular, you will be able to that patient will be able to tell you that it started on this day, especially like on that hour it started, because it's associated with some of the event. Whereas the muscle disorder is a bit more complex, because if it's an inferior lateral pterygoid muscle is affected, then what happens is, because it's a depressor, on the same side the teeth will disclude, and because the jaw will tilt on the other side, you have canine which can have a heavy contact. If it's elevator muscles are affected, then patient may come to you and say, look, something's not feeling right, my bite doesn't feel right. And you check the occlusion, you can't really find any difference. And that could be one of the reasons why you don't find anything, because the elevator muscles are firing up and closing tighter, and you can't really find reason, but patient feels a difference because of the slide. The fifth reason is loading of the joint. Now, if you're loading the joint in musculoskeletally stable position, which is a CR, and if you're loading the joint in that position, and if patient feels pain, then it's almost always intracapsular, because that's where there is a derangement. Because when you have a capsule which doesn't have any innervation, you can apply as much force as possible on the disc with the condyle, and the patient won't feel pain. However, when the disc is displaced and you are pushing on the retrodiscal tissue or somewhere else, patient may feel pain. And however, this is not the case if the muscle painful. So if you use some sort of a deprogrammer like Lucid or Leaf Gauge is really good example to assess this feature. If you use a Lucid and guide patient into CR, and patient bites very hard and there is no pain, that could be that patient might have a muscle pain, but there is no intracapsular disorder. The functional manipulation is also another way to assess. The way you can do this is use a wooden tongue spatula and ask patient to bite on the same side where the pain is arising. So if patient comes to you and say, I have a pain somewhere in this area, and you are unable to find out whether it's intracapsular or from the muscle, you ask patient to bite on a wooden tongue spatula on the same side. If the pain is getting worse, then it's pain coming from muscles, because muscles acting on that side. Whereas if the pain is relieved, then it's coming from the jaw joint, because jaw joint is distracted and relieves the pressure in the joint and relieves the pain. So you need to understand the concept of this, and it's very important diagnostic tool you have there. The seventh diagnostic tool is auriculotemporal nerve block. Now this is something I do not practice, and you need a really good skill in order to practice this. But if you are managed to do this, then if you put the injection in the joint and the pain is reduced, then it's the pain is coming from the joint. If pain is not reduced, then the pain is associated with muscles. So in this lecture, we discussed about various examination methods and how to do differential diagnosis between intracapsular and muscular disorders. In next video, we will discuss about classification of the temporomandibular joint disorder developed by Dr. Bell, modified by Dr. Jeffrey Oxen. We will also discuss about some of the main conditions and features of the disease temporomandibular disorders we see in general practice.